morning, everyone. On behalf of the Student Scientific Association of Medical University of Silesia in Katowice, I would like to thank you for taking part in International Medical Congress of Silesia 2024. My name is Radosław Dutrak, and it's my pleasure to coordinate and chair session of Surgery 2. I'd like to welcome the esteemed jury, President of the jury, Professor Tomasz Urbanek, and members of jury, Dr. Dorota Łyko-Morawska, who is joining us today online, Dr. Agnieszka Wiórek, and Dr. Marianna Łoskot. I'd like to begin by explaining basic rules of the session. The order of the presentations will be the same as in the abstract book. Maximum time for the presentation is 7 minutes, followed by 3 minutes of the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Now a few information for our esteemed jury. I'd like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. Please bear in mind that this assessment will be verified. All the presentations and the discussion must be run in English. Even if the commission will ask the question in Polish, the authors of the work are obligated to answer in English. We kindly ask the jury to assess 4 elements on the scale of 1 to 5. Scientific value, way of presenting, discussion, and creative own contribution of students. When the session ends, we kindly ask you to give the cards back to the moderator, and that would be me. That concludes this preliminary part of the session, and we can proceed to our first presentation. To znaczy, ostatecznie nie będzie to problemem. Z tego względu zachęcamy do prezentowania po angielsku, dlatego że mamy... To znaczy, my też wcześniej maile takie informacyjne tutaj wysyłaliśmy do wszystkich. To znaczy, ostatecznie można oczywiście prezentować po polsku, bo... Mogą jak najbardziej... Mogą być po polsku, jeżeli były przygotowywane. So I would like to invite the first presenter, who will present the work Anti-Platelet Drug Resistance in Vascular Surgery Patient, Clinical Implications.
Okay, good morning, everyone. I'm Anna Gwóźdź, and I would like to present today the study that Dorota Woźniak and I conducted together, and it's about antiplatelet drug resistance in vascular surgery patients. Okay. The majority of the patients undergoing vascular surgery are typically prescribed to antiplatelet drugs, such as ASA and clopidogrel. The term antiplatelet drug resistance refers to a situation in which certain patients, despite receiving the normal antiplatelet treatment, do not achieve the anti-aggregative effect. This subject is better known and studied in the field of cardiovascular surgery, but there is insufficient data regarding both the frequency and underlying causes of antiplatelet drug resistance observed in vascular surgery patients. The purpose of this study was to evaluate the patient functionality among these patients, also to ascertain the incidence of high complications compared to standard expectations, and furthermore, to assess whether resistance to antiplatelet medications warranted alteration in therapeutic regimen. Our patients group was 100 patients, but the 6 were excluded from the final examinations because they were previously being diagnosed with resistance to antiplatelet drugs, and their test results in this study did not show resistance. There were 64% of males and 36% of females with age ranging from 42 to 100. They were treated at the Department of General Surgery, Vascular Surgery, Angiology, and Phlebology of the Medical University of Silesia in Katowice. The platelet function assessment was performed via two distinct platelet function tests, one utilizing ADP, and it was to assess resistance to clopidogrel, and the other one utilizing arachidonic acid to assess resistance to ASA. 90% of the patients underwent endovascular procedures and 10% had an open bypass surgery. The most common comorbidities were hypertension and diabetes. Resistance to ASA was identified in 62% of the patients. Resistance to clopidogrel was identified in 40% of the patients, and resistance to both drugs were identified in 32%. For further analysis, we divided our patients into 4 groups. The first one, non-resistant one. The second one, the clopidogrel resistance, but only resistance to clopidogrel without being resistant to ASA. The third one, ASA resistance and resistance to both. We were surprised that there was no significant value and no significant difference between hemorrhagic complication and ischemic complications in any of the group. What is the clinical meaning of this? It is to modify the treatment, and in case of resistance to both drugs, the treatment was changed to ticagrelor. After analyzing ASA-resistant tests, there is a statistically significant difference between the ASA-resistant group and resistance to both one. The latter group had lower test scores, which may indicate even higher resistance. In case of clopidogrel test resistant, there was also a statistically significant difference between a non-resistant and ASA-resistant group. And in this case, ASA-resistant had lower test scores despite not being resistant to clopidogrel. We've reached 3 conclusions after this study. The first one is that antiplatelet drug resistance occurs relatively often in vascular surgery patients. Furthermore, dual resistance to antiplatelet drugs indicates lower test scores than a single one. And the topic of antiplatelet drug resistance among vascular surgery patients remains insufficiently explored. And consequently, there's a need for additional research to enhance the care patient strategies. Thank you.
Thank you very much for the presentation, and we invite our jury to the discussion.
To ja gratuluję pracy. Taka pokaźna grupa pacjentów, naprawdę gratuluję. Proszę mi powiedzieć, bo z tego co pamiętam, przeważali mężczyźni, tak, w badaniu.
Yes.
Natomiast nie pamiętam już o jakimś tam znikły procent był kobiet, ale jak mówi piśmiennictwo, czy płeć też ma wpływ na tą oporność, na te leki?
No, there is no difference between significant difference between men and females.
Myślę, może pani odpowiadać po polsku, bez problemu,
tak, okay.
Spokojnie.
Było takie narzucone. Nie było statystycznie istotne, czy to ma wpływ płeć na to. Tak samo wiek też nie wpływał na występowanie częstości tej oporności w przypadku żadnych leków.
Aha, okej, to bardzo, bardzo przepraszam w takim razie, ale to tym bardziej gratuluję. Dziękuję.
Dziękuję. Thank you.
Dorota Łyko, ty możesz zadawać pytania? Ty słyszysz? Bo jesteś na ekranie, ale nie wiem.
Tak, oczywiście, ja słyszę, panie profesorze.
No to masz 10 prac przed sobą.
Tak, mam. Z wielką chęcią wysłuchałam pani ten.
Rozumiem,
że
dyskusję mamy... udział w dyskusji, bo no to nie tylko o to chodzi, żeby państwo pracę powiedzieli, ale żebyśmy też ich zainteresowali tej dyskusją, więc...
Tak, oczywiście, ale
zapraszam. Ja nie biorę udziału w dyskusji przynajmniej w 5 pracach, bo są ode mnie.
Rozumiem. Rozumiem, że po angielsku prowadzimy dyskusję, tak?
Jak najbardziej.
Okay, so I have a question, because when we analyze the results of the resistancy, we have three different points. We can say three different measures. So where there is a resistance, immediate we can see like this, that the outcome is middle, that we don't know exactly where to put the patient in a group, and the patient is no resistance. Where did you put the patient which were in this middle group?
We didn't have that kind of the group. We just divided them into resistant or non-resistant groups.
Okay.
And that was it.
Okay, thank you so much.
Thank you.
Thank you very much. Do we have any additional question, maybe from the other participants? Yes?
So what's the modification of the treatment in case of single resistance?
So in case of resistant to ASA, we used, the treatment is modified to clopidogrel and heparin. And in case of resistant to clopidogrel, the treatment is heparin and ASA.
Thank you very much. Unfortunately, our time has run out, so thank you once more. And now we'll proceed to the second presentation. So we invite the presenter of the work entitled Clinical Outcomes in Patients with Peripheral Arterial Disease and Femoral Amputations.
I'm sorry. Good morning. My name is Klaudia Jurkowska, and I'm a student of Medical University of Silesia in Katowice. Today, I would like to present clinical outcomes in patients with peripheral arterial disease and femoral amputation. Femoral amputation is a surgery procedure which may be necessary for a wide variety of reasons. For example, trauma, infection, tumor, or vascular compromise. The main of the study was analyze evaluation of complication of femoral amputation, with particular focus on patients who were alive after femoral amputation and how their further prognosis will be. The presented data has been collected at Department of General and Vascular Surgery, Angiology and Phlebology in Katowice. We had 86 patients, of which 27 are female and 59 are male. The date range has been collected from January 2022 to December 2023. We also focused on risk factors, causes, and lengths of hospitalization. Moving on to our results, 72% patients had primary femoral amputation, and the main cause of hospitalization was chronic leg ischemia. Some of the patients had post-operative complications. Some of them had general complications, for example, system infections, and another patients had only local post-operative complications, for example, wound healing disorders. We also paid attention to the length of hospital stay, but we didn't notice any correlation between dead patients and their length of hospital stay. 21 patients died during the hospitalization. And now I want to show you how important the post-operative care for the patient after femoral amputation will be. We made follow-up till May this year, and we noticed that 33.3% patients who had femoral amputation in 2022 died.
and this number of dead patients, but the patients who had femoral amputation in 2023 has increased, and it's almost 39%. To sum up, femoral amputation, like any surgery, can cause some complication, but it can be one of the main procedure who can save people, which can save patients' life. Most of the patients who had femoral amputation from January 2022 to December 2023 didn't have any post-operative complication. But a lack of post-operative care for the patient after femoral amputation can reduce their further prognosis of life, because general amount of patients after femoral amputation in 1 or 2 years after this procedure is almost is more than 50%. It raises a conclusion that providing care providing care of patients who are after femoral amputations would help reduce dead patients and improve the quality of their life. Thank you for your attention.
Thank you very much. Do we have any questions?
Yes. Go ahead.
Okay, so during your presentation, you told us about the time of hospitalization of the patient. Did you met during the analysis the documents and papers? Did you find patients who didn't give the permission for amputation in the first days, for example, of hospitalization, and after a few days they changed their mind or not even?
We saw that some of the patients some of the patients were qualified to another procedure, but then they didn't qualify, so they must have femoral amputation.
I'm asking the question because it will enlarge the day of hospitalization, yes? Because sometimes the patient for a few days, first day, they don't want to have the amputation. They do not give the permission to do this, to do the procedure. That's why I didn't find this group in the presentation. That's why I was asking. Thank you very much for your answer.
Thank you.
So congratulations, first of all.
Thank you.
And I would like to ask, during the data gathering, did you discriminate between subgroups of patients based on their comorbidities and their initial clinical state at the point of qualification for surgery? Or did you maybe try to look at the pharmacotherapy implemented by the attending physicians prior to the surgical decision that only amputation may potentially save the patient lives?
In this group, femoral amputation is the main way to save their lives. So sometimes, how I mentioned, some people try to another procedures to intrude in this patient, but it's impossible. So they must to have been femoral amputation.
Okay, but I'm thinking about that certain patients may have been, for example, ASA class 2, or the other would be ASA class 3, based on the other comorbidities and systemic disabilities and instabilities that may have occurred during the hospitalization, and that may have influenced their follow-up periods in the postoperative during the postoperative hospitalization. So
We we only had a class of chronic leg ischemia or acute leg ischemia, and this how influence or on femoral amputation. But in the future, we don't have this state.
Okay, thank you.
Thank you.
Thank you very much. Unfortunately, the time for discussion has run out. So I'd like to invite our next presenter, who will present the work Medical Compression by Short Stretch Bondage. How many tries does it take to acquire the proper technique?
Okay. Good morning, ladies and gentlemen. My name is Maria Kuczero-Jarosz, and with Emilia Boris, we have conducted a study regarding medical compression by short stretch bandage and how effective is the training of medical students in that regard. Today, I would like to present this study to you. So medical graduated compression by short stretch bandage plays a significant role in phlebology, as it is one of the intensive form of treatment of lymphatic and venous system diseases. Currently, medical compression bandaging is being used as a form of treatment of diseases such as severe venous insufficiency, deep vein thrombosis, and lymphatic edema. But medical compression by short stretch bandage only works when the proper sub-bandage pressure is achieved. Adequate pressure allows the blood or lymph to be pushed, which is the point of the treatment. To achieve this right pressure, you need the right technique and also have a lot of experience in that matter. A study from 2017 has shown that medical compression and achieving the proper sub-bandage pressure is a problem not only for non-medical people, but also for healthcare professionals. As in that study, the nurses were trained in the compression bandaging, and even after training, only 58% of them achieved the right sub-bandage pressure. So we wanted to adapt that study to medical students, and we wanted to find out how hard it is to teach the medical students the proper technique, how many tries will they need to learn, and will they achieve the proper pressure. So we taught a group of 13 medical students how to bandage using 2 Rosidel K short stretch bandages, and we measured their results with Kikuhime sub-bandage pressure measuring device. Can you click that? Can you click on that video? Is it working? Can you click, please, here? Oh. Thank you very much. So each student was presented with a tutorial of how to bandage the double layer compression bandaging, similar to the one on the video before, but unfortunately, I don't know why it's not working. Each student could try as many times as they felt was needed until they felt comfortable with their bandaging abilities. And everyone bandaged the same leg of the same person from metatarsus to tibial tuberosity. And everyone had, on their final trial, had the sub-bandage pressure measured at the ankle level by Kikuhime device. Okay, so what were the results? Regarding the number of trials, an average number of trials was about 4, but it ranged from 2 to 20. And what is an interesting fact is the fact that more than half of the students decided they only needed 2 trials to achieve perfection, I would say. So they felt pretty confident in their abilities. Regarding the time of the trials, the students bandaged between 3.5 minutes and 17 minutes, but on average, one trial took about 7 minutes. And in most cases, the first trial was the longest one, and all the others were shorter. Our desired result of sub-bandage pressure was to achieve at least 40 millimeters mercury while laying. And during activity, we expected an increase of this sub-bandage pressure, but we did not want it to exceed 70 millimeters mercury. And what were the results? About 50% of the students bandaged in the correct range, both in lying and while walking. About 15% bandaged too tightly while lying, and twice as many bandaged too weak. While walking, about 40% of the students bandaged too tightly, and 50% did not achieve the proper pressure even during activity. And our record pressure was up to 153 millimeters mercury, which is very high. On this graph, we can see a correlation between the number of trials and the percentage of the correct results achieved. You can see this in the green parts of the graph. This is the right. This is the right range. And as we can see, there seems to be no correlation between the number of trials and the results, because even people with 2 trials, a lot of them achieved the proper pressure, and some of the people who did more than 4 trials could not achieve the right pressure. And there was also a difference between people who achieved the pressure while lying, but some of them did not achieve the right pressure while walking because some of them were still too high. In conclusion, compression bandaging is not as simple as it seems. Medical compression bandaging requires both the right technique and having a lot of experience in that matter. And it still remains a problem, even for soon-to-be professional healthcare professionals, even after the training. Thank you.
Thank you very much. And we invite our jury members to ask the questions. Do we have any questions?
I have a question, but I'm also interested. Congratulations for your work. You told during your presentation, that even for the medical staff, it can be problematic, yes. How do you think, how long will take, for example, to teach the proper technique for an older patient, like 60, 70 years old?
You mean how long do we teach a patient that?
Yeah, for example, in your mind, during your experience when you were providing this study with your colleagues, yes, at the medical staff, for example, what, in your opinion, how long it will take for a patient, which will be the older patient?
Yes, I think it will take a lot of time because, well, like I said, we taught medical students who already have some of the experience with that. And the older patients, well, there will be the problem with the movement because it's hard to bandage yourself. We have to teach some part of family or some friends to do it. So I think it would be problematic. It would definitely take more than 2 trials because we were checking, we were conducting our study on healthy, active students who don't have any problem with sitting and taking the leg of the patient. And our patient also was a healthy student. So I think it would be much harder with a patient who experienced pains and also someone who's not educated in the matter to just do it.
Thank you very much.
Okay, so is the sub-bandage pressure over 70 millimeters mercury always incorrect?
So that's kind of complicated because in some of the patients, of course, the higher pressure will be needed, but we needed to choose some kind of average patient, and an average patient will tolerate well the range between 40 and 70 millimeters mercury, but there will be some severe cases in which the patient will need the sub-bandage pressure to be over 70 millimeters mercury.
Thank you very much for interesting presentation and discussion. And we had medical compression, and now it's time for non-medical compression. Does it matter? So please welcome the next presenter.
Good morning, honorable jury, ladies and gentlemen. My name is Ewa Wiadelny, and along with Aleksandra Zaremba and Kamila Wolak, we've conducted a study about non-medical compression. So edema is a widely known problem in our population in vein disorders such as chronic venous disease, especially in the population of women, because being a female, among other factors such as age, genetics, obesity, pregnancy, or long hours of sitting and standing position are risk factors. On the other hand, lymphatic edema can occur in patients after surgical procedures and injuries. So medical compression is one of the oldest non-invasive methods to prevent and treat patients with previously mentioned disorders, improving the outflow of venous disease in blood by applying a proper class of compression significantly reduces swelling and consequences of venous stasis. We distinguish 4 classes of medical compression, but in our study, we focus on using second class of compression. But what we have to remember is that we are experiencing compression in our daily life by wearing some kinds of clothes, shoes, or even a badly fitted scrubs. So the aim of our study is that we ask ourselves a question: if we are using compression as a treatment, what about compression that we are experiencing in our daily life? What we mean is that fashion encourages most young women to wear a tight-fitting pants. So in our study, we compared pressure exerted by tight-fitting pants to that of second-degree medical compression. And the Kikohyume is a device that allowed us to take all measurements in selected points by putting a sensor under pants or compression stocking. And here we chose 5 typical points from thigh to ankle. Here you can see those points, and all measurements were taken in sitting, standing, and supine position. So we started by measuring a pressure exerted by second-degree medical stocking, and here are the results. You can see that around the ankle in point B, the pressure is the highest, and then it's gradually decreasing towards the higher parts of the leg. And here we wanted to show you a comparison between a pressure exerted by second-degree compression stocking in different positions. And as you can see, there is no significant differences. So we've collected our results of most worn tight-fitting pants among young women around us. Pants that we measure have an addition of elastin, and there are several styles in today's fashion, but we focus primarily on a skinny type with an addition of few slim jeans. So those are the results collected from 15 skinny jeans that we measure, but to simplify the chart, we are going to use arithmetic mean of our results. And what is worth noticing that the pressure is the lowest in the point B around the ankle, and then is gradually decreasing to become the largest in point B and C in the calf. So next we compared pressure exerted by skinny jeans to that of second-degree compression stocking. And as you can see, the pressure is gradually increasing from point B through B1 to C in skinny jeans. On the contrary, the pressure exerted by second-degree compression stocking is the highest in point B, and then it's decreasing through point B to point C. And to show even better our results, I present you a graphic version where you can perfectly see the difference in first 3 points between skinny jeans and compression stocking. And here we want to show you how the pressure exerted by skinny jeans is different in different positions. And as you can see, you can still see the increase in the first 3 points, but the growth is the largest in the point C, in sitting position. So slim jeans that we use in our study, so similar results to skinny jeans, but the pressure that was measured was overall smaller because this type of jeans is usually less tight in the lower parts of the leg, but you can still see the increase in the first 3 points and especially in sitting position. So to sum up, medical compression is used to treat patients and in prevention. So tight-fitted pants that has showed us such different results might be potentially harmful with someone with tendencies for edema or venous disorders, because increased pressure on the calf can cause difficulties in venous return. We think that is an issue that should be taken into further consideration because we spend many hours sitting in our work, university, or travels, and as a woman, we are more likely to develop this kind of disorders. Thank you for attention. We will gladly answer your questions.
Thank you very much. And I see co-authors of the work joining for the discussion. So do we have any questions?
Yes. So congratulations on quite interesting and creative take on such a matter. And I would like to ask you, having that knowledge that the skinny clothes are not equal to medical stockings and may potentially even be harmful, how would you implement it in your now daily lives or daily practice?
Well, you can see that we all wear dresses, so we already implementing that. But we wanted to show other women that we should be really, really careful about what we are wearing every day, and not to follow the fashion blindly, because it's not always worth it. Thank you.
Maybe I'll add only that maybe not only the woman, but also the man. Today's fashion is also creating trousers, skinny trousers for men. So
and
do not exclude this group.
Thank you, because that is my question. You show us lots of types about women, yes, and how skinny trousers, skinny jeans affects to a man, to teenagers. What do you think?
Well, we didn't actually take men in this study into consideration, because if we walk into any store that sells jeans, it is clear that women's jeans are much more tight and more fitted than men's. And that's why we focus on us.
Okay, thank you. Przepraszam, ja przyjdę po polsku, bo aż nie wiem, jak to powiedzieć. Mi chyba bardziej chodziło o to, ja też zajmuję się urologią i chodzi o to, że u nas na klinice my zauważyliśmy bardzo dużą ilość nastolatków z żylakami powrózka nasiennego. To miałam na myśli, że takie obcisłe spodnie bardzo wpływają na temperaturę w jądrach, później właśnie tworzą się żylaki i też w przyszłości być może problemy z płodnością, więc to taki aspekt, tego chciałam zwrócić uwagę na.
Yes, we noticed that. That's why we added the point H and F to our study, but our study group was mostly the women. That's why the study is mostly about us.
Thank you.
Jeszcze z sali?
Did you consider other types of pants?
Yes, we consider. We also measured a few of the straight pants and few leggings, but the leggings showed almost no pressure, and the straight jeans are very wide around the ankles, so the little pressure that they exerted was not significant.
Okay, thank you.
I remember one of the studies performed somewhere. I don't remember where this was. Probably there were much worse results in surgical scrubs, which are not elastic. And if someone is taking something which is not as big as should be, especially the tie, it's compressed. So I think that this is the big field open for discussion and also for the research. So you are just started this, and I think that there is a topic to go deeper in the future. But if you go to the shops with good underwear right now, supported by the good companies, on many of them, I mean, like socks, you will find the information compressione gratuita, compression gradual, compression stocking. So the companies see the problem, but of course, in a daily practice, only some of them will implement this. This is usually much more expensive, but this is the trend to implement the physiological condition into of the venous outflow into the fashion. However, as you mentioned, most of the companies thinks how this looks like, yeah, only.
Thank you.
Thank you very much. And now we'll invite the next presenter who will present the work entitled Preoperative NLR in Predicting Postoperative Complications in Patients with Colorectal Cancer.
Hello, everyone. My name is Victoria Bajek, and I'm going to present our work, which is called Preoperative NLR in Predicting Postoperative Complications in Patients with Colorectal Cancer. So here we've got a brief presentation plan. Okay, so colorectal cancer is the third most common malignant neoplasm and the second most deadly one worldwide. But in Poland, it's the second most deadly one in males and the third most deadly one in female. According to WHO, as you can see here, okay, it's here, it makes up 10% of all diagnosed cancers yearly. The global number of new releases is predicted to reach 3.2 million in 2040, which means an increase by almost 60% in 15 years. So it's such a big problem. So to carry out the most effective treatment, which is based on surgical treatment and chemotherapy, it is important to identify patients with poor prognosis and risk of recurrence. So what actually is NLR? NLR, which stands for neutrophil to lymphocyte ratio, is one of the most effective biomarker to predict prognosis in various types of cancer. But as you can see, not only, it is used also in different types of clinical situations, such as sepsis, COVID-19, or cardiovascular diseases. So the aim of our study was to analyze the association between preoperative NLR, clinical data, and post-operative complications. We reviewed 71 patients' clinical data who underwent surgery for colorectal cancer in the Department of Gastrointestinal Surgery in Katowice between March of 2023 and March of 2024. We calculated the NLR and we determined cutoff value, so you can see it here, as 3.7 for development of complications with sensitivity of 53.7 and specificity of 70.6%. We divided our patients into two groups, those with NLR less than or equal 3.7 and those with NLR higher than 3.7. And the predominance in males was observed in both of these groups. As you can see, the lower median age and higher BMI was in this group with lower NLR. And this P was statistically important, as you can see on the right. Oh, sorry. Okay. So presence of symptoms, occurrence of comorbidities, positive history in terms of cancer in family, and positive history of smoking was similar in both of these groups. Some of the patients have reported symptoms, and the most common ones were abdominal pain, constipation, change in bowel habits, and loss of weight. Some of our patients, most of our patients had any kind of comorbidities, and the most common one were hypertension, diabetes mellitus type 2, lipid disorders, and benign prostatic hyperplasia. So now we can move on to surgical procedures, and majority of our patients underwent a right hemicolectomy, then proctosigmoidectomy, and then left hemicolectomy. The median operation time was 3 hours and 25 minutes. Majority of our patients were classified in group 3 in ASA classification, and we have found no correlation between preoperative NLR operation time and type of the surgery. In total, 17 of our patient experienced complication, and 9 of them had to be reoperated on. As you can see, most common one were circulatory insufficiency, sepsis, increased inflammation parameters, and anastomotic obstruction. The most common location of colorectal cancer was in the sigmoid colon, then cecum and rectum, and then in transverse colon. And majority of our patients were classified in 1A and 2A in TNM staging classification. And we have found statistically significant positive correlation between preoperative NLR and TNM staging. So to sum up, the predominance in males is observed in the colorectal cancer, with a higher NLR was associated with lower BMI and higher age. No association between NLR, occurrence of comorbidities, presence of symptoms, complication, or positive family history of cancer or positive history of smoking was noted, and higher NLR was correlated with more advanced TNM staging. And thank you so much. Now, if you have any questions, feel free to ask.
Thank you for this report. Is this parameter NLR some kind of standard of care in regards to diagnostics in this patient? So you have the group of 71 patients, but it's obligatory to do this in the department where you did this research, or it's some kind of clinical studies only looking for the parameters which can potentially predict these factors as you mentioned? So do you have any guidelines that this should be provided in all the patients?
So thank you for your question. So it is not obligatory, but I think it's really important. The group of our patients was only 71 because not all of the patients had data to calculate it in, but it's not obligatory, so they don't calculate this NLR before doing a surgery, and we had to do it on our own.
Do you have any data that this can be related to the advancement of the cancer also in other malignancies?
To be honest, in literature it was used, but I'm not sure if it was used just only for clinical studies or it is used.
But I mean the kind of malignancy, because you had the colorectal cancer, but what about the other cancers? Do we see the same observations, same findings regarding the advancement of the disease? Because perhaps this can be the marker of the disease and disease advancement in patients with malignancy.
So we found studies where the NLR was a predictor factor in thyroid cancer also, but then there are no many more studies.
Okay, thank you.
Okay, so congratulations as well. And in relation to the professor's question, because you've mentioned that you've calculated this ratio on your own, so it's not like a routine diagnostics and routine measurements that we take. But have you been in contact with attending surgeons? Because if it turns out that the NLR ratio is correlated with the TNM staging, did you perhaps swap information with the surgeons? Did it in any way influence their attitude towards the incoming surgery or ongoing surgery or post-operative period?
So to be honest, we were not talking with surgeons about this topic, but as you can see, most of patients were in 1A and 2A, so the prognosis and the risk of recurrence was not that high. So I think their prognosis was kind of good. So,
and we found studies where, because our conclusion was the higher NLR was correlated with more advanced TNM staging, but we found studies where
there wasn't correlated, but there were independently risk factors of poorer 5-year survival rate or overall rate.
Maybe it's something to consider during the follow-up period.
Yeah, I think we will do it.
Patient
Thank
monitoring.
You. Yeah, thank you.
Thank you.
Thank you very much. And unfortunately, the time for discussion has run out. So now we should proceed to our next presentation, critical leg ischemia treatment in the post-pandemic era. But we did not receive the presentation from the authors. So are the authors present or are they online? So
I know that the abstract was sent, but then
okay,
probably we don't have this paper.
Okay, we understand. So in such a situation, we ask the jury to cross out the presentation number 6, and we will proceed to the next presentation, metastatic renal cell carcinoma to the pancreas, clinical pathologic characteristics and surgical outcome.
So, good morning, ladies and gentlemen. My name is Joanna Rak, and today I would like to present our research about metastatic renal cell carcinoma to the pancreas and its clinico-pathological characteristic and surgical outcome. So, among all of pancreatic malignancies, metastases to the pancreas are a very small percentage. However, in this small group, metastatic renal cell carcinoma is one of the most common metastases. MRCC has often asymptomatic course and occurs many years after radical nephrectomy, and that's the reason why the diagnosis might be challenging. The aim of our study was to describe the incidence, clinico-pathologic characteristics, surgical treatment, and outcome of MRCC. We retrospectively analyzed the medical records of 25 patients who underwent surgery for MRCC to the pancreas in the Department of Gastrointestinal Surgery from 2014 to 2023. And now let's move on to our results. So the mean age of our patient was 64, and the age ranged from 52 to 77 years. Also, the majority of our patients were men. There were 60% of men and 40% of women. Also, the mean period between nephrectomy and pancreatic metastasis resection was 10 years, with a minimum 1 year and maximum 29 years. In 16 cases, and that's 64%, primary nephrectomy site was left, and almost every patient, that's 96%, underwent total nephrectomy. As I mentioned before, most of patients were asymptomatic, and it was also confirmed in our analysis. In our study, 92% of patients were asymptomatic, and among reported symptoms, there were weight loss, nausea, and diarrhea. 60% of our patients had comorbidities, and among them the most common was arterial hypertension and type 2 diabetes. Our patients included into study underwent different procedures. The most common was distal pancreatectomy, and it was conducted in 15 cases, and that's 60%. But there were also pancreatoduodenectomy, and one person underwent total pancreatectomy. The mean duration of surgery was 343 minutes, and the minimum was 80 minutes and the maximum 530 minutes. The median blood loss was 400 milliliters, and 20% of patients received the blood surgery during the blood transfusion during surgery. The median duration of post-operative hospitalization was 9 days, and as you can see, the most of our patients, that 60%, were classified by anesthesiologists as ASA-free, and the residual tumor resection was classified as R0 in 92% of cases. Histopathology examination revealed that in 72% of cases, the pseudocapsule was present, and also the most common histopathological grading was G2, and that was 56%. And as you can see, the most common location of metastases to the pancreas was the tail, and that was 28%. Histopathological examination revealed also that the amount of metastases ranged from 1 to even 44 metastases, and the average number of tumor was 4, with the mean size of tumor 26 millimeters. Also, 56% of patients had multifocal metastases. Majority of patients, that's 96%, had some lymph nodes removed. The median number of resected lymph nodes was 18, and as you can see, only in 3 cases, and that's 12%, the histopathological examination confirmed the presence of metastasis in lymph nodes. And in these 3 cases, number of infiltrated lymph nodes ranged from 1 to 3. There were no intraoperative complications. However, postoperative complications occurred in 36% of patients. Also, 2 patients required a transfer to the intensive care unit, and 1 patient required 2 reoperations due to the intra-abdominal hemorrhage. Also, the postoperative mortality was 8%, and among postoperative complications, the most common was pancreatic fistula grade B and acute circulatory failure. However, among complications, there was also intra-abdominal hemorrhage, wound abscess, abdominal abscess, or incisional hernia. To conclude, metastatic renal cell carcinoma is usually asymptomatic, and it emerges more than 10 years after primary nephrectomy, often as multiply foci. Also, usually partial pancreatectomy is performed. However, some of the patients require different type of surgery due to the MRCC in the remaining pancreatic parenchyma. Thank you very much for your attention.
Thank you very much. Can you tell us, because we speak about the patients with advanced metastatic disease, what is the patient survival after this kind of procedures? Because you analyze the historical data. I mean, there's retrospective analysis. So how long was the follow-up and the patient lifespan in this group?
Okay, so according to the information which were available in the medical records, usually the follow-up was about 2 years, but we don't know what was next. That was the last, the 2 years after surgery was the most common last time when the patient.
So how many of them died within these 2 years?
We didn't have this information.
So if you saw the data of the 2 years, you should have also information if they are still alive or not. I don't believe that 25 patients with metastatic cancer are still alive. So I think that in these patients, to answer the question, if this is really worth to do such a surgery in advanced disease, it's crucial to assess the mortality rate and the survival in these patients. Okay, thank you.
Okay, I have one question. During your presentation, I didn't notice those patients which you presented, they have the metastatic only in the pancreas, but did you find another also region or another places of metastatic? Because as we know, the renal cancer usually have many places when they give metastasis.
Okay, so one patient had the metastasis in the in thyroid. Also, a few patients, I think that was about 5 of them, had metastasis in adrenal glands, and one patient had metastasis in the uterus, and yeah, and I think that's all.
Okay, thank you.
Thank you.
Thank you very much. Do we have any additional questions? Maybe from the room? Yes, please do go on.
So you mentioned that there was a patient that needed 2 surgeries. Did that patient survive? Do you know that?
Oh, okay. So this patient with who required the operation 2 times, unfortunately, that woman didn't survive. Yeah, and she had the intra-abdominal hemorrhage after the surgery.
Thank you.
Thank you.
Thank you very much. And unfortunately, the time for the discussion has run out. I'd like to warmly welcome the next member of the jury, Professor Wacław Kuczmik, who joined us today. And we will now proceed to the next presentation entitled Biological Graft Implantation Procedures in Patients with an Infected Artificial Graft, Retrospective Analysis.
Good morning, ladies and gentlemen. My name is Wiktor Kruczek, and I'm a student from Medical University of Silesia in Katowice, Poland. Today, I have a pleasure to present my original research results, a retrospective analysis of pioneering biological graft implantation procedures. Vascular surgery stands out as one of the most rapidly evolving areas of medicine. The utilization of synthetic vascular prosthesis has increased. Unfortunately, this has also contributed to a rise of graft-related infections. Vascular graft or endograft infections remain rare but severe complication following vascular surgery interventions. It is estimated that from 1 to 6% of patients undergoing peripheral vessel reconstruction and from 0.5 to 4% of patients undergoing aortic reconstruction may be affected with graft infections. 5-year mortality in conservative treatment with antibiotics is 45%, increasing to 75% in patients with severe infection. In addition, in recent studies, a conservative treatment with antibiotics was identified as the predictive factor for mortality in vascular graft infections. Vascular surgery offers a range of synthetic grafts. Some of them are visible on the slide. Today, I would like to focus on the newest solution, fully biological vascular prosthesis made from bovine pericardium and providing an alternative for a patient with an infected synthetic prosthesis or in case of the absence of a good quality own material in high-risk patients. Our study aimed to, firstly, evaluate the safety and efficiency of biological graft implantation procedures, and secondly, assess crucial mortality risk factors. We performed a retrospective analysis of 12 patients. All of them were treated for vascular graft infections with biological xenograft implantation in the Department of Vascular Surgery between January 2020 and December 2022. Let's move on to the symptoms. The most common symptom of the graft infection was purulent infection site reported in 9 patients, followed by groin pain presented in 5 patients. In preoperative blood tests, 7 patients had elevated white blood count with the mean of 10.8 thousand per microliter. 8 patients had low hemoglobin level with the mean of 11.8 gram per deciliter. In addition, all of our patients had elevated CRP level with the mean of 66.8 milligram per liter. The most common bacteria observed in cultures collected from infection site was medicine-resistant Staphylococcus aureus. In the blood, the most common observed bacteria were medicine-resistant Staphylococcus aureus and Staphylococcus epidermidis. In addition, in bacteriological cultures from infected prosthesis, the most common bacteria was medicine-resistant Staphylococcus epidermidis. 6 of our patients were assessed to the 4th group of American Society of Anesthesiology scale, while 2 patients were assessed to the 5th group. The most common treatment with xenograft was aortofemoral bypass performed in 6 patients, followed by aorto-bifemoral bypass and femoro-femoral crossover bypass. We didn't observe statistical significant difference in procedure duration between different treatment methods. The median duration of the procedure in all of our patients was 282.3 minutes. Also, we didn't observe statistical significant difference in the duration of hospitalization between groups. The median duration of hospitalization in the whole group was 18.5 days. In the early postoperative period, 6 complications were noted: 3 sepsis treated with antibiotics, 2 colon perforation treated with partial colon resection and colostomy, 1 hematoma treated with surgical drainage, and 1 acute limb ischemia treated with surgical thrombectomy. In this period, 5 patients died, 3 due to sepsis and 2 due to the multi-organ failure. Therefore, in-hospital mortality was 41.67%. The median time of the follow-up in the whole group was 96 days. However, follow-up time in patient discharge from the hospital was 662 days. Worth to notice is the fact that in our group, the reinfection rate was 0%. The 3-month survival was 50% in the whole group and 51.13% among patients discharged from the hospital. Here, we present Kaplan-Meier survival curves on the left from the whole group and on the right from the patient discharged from the hospital. To find the predictive factors for the overall survival, we perform a Cox proportional hazard regression analysis with listed variables. In the model, only the occurrence of in-hospital complications proved to be a significant predictive factor for overall survival with 15.88 hazard ratio. To prove the significance of our findings, here we present the overall survival between groups with and without in-hospital complications. After the study, the conclusions have been made. Firstly, vascular graft and endograft infections typically present with systemic and local symptoms, including elevated C-reactive protein levels and white blood cell counts, along with purulent infection site. Biological xenogenic grafts offer a new treatment option with low reinfection rate. Despite high overall mortality of biological graft implantation, this method proved to be a valid option for treatment in the vascular graft and on the graft infections. And last but not least, early postoperative complications were predictive of mortality, emphasizing the criticality of this period. I'm very grateful for your attention. If you have any questions, please feel free to ask now. I do my best to answer them.
Thank you very much. And I see a second Kato joining for the discussion. Do we have any questions? Yes?
According to your presentation, when you will sum up all the results, and in your opinion, which treatment option will be the best for the patient? Which material is the best for the patient?
I think that's a very great question, because all the patients with vascular graft and endograft infections are severe patients. They are difficult to treat. So still, the best treatment method for patients with infected grafts are the own material. It's mostly the superficial femoral vein, and it's the best treatment. But there are some patients that can not be able to stay alive after this operation. So we have to try to use the other material. For example, those biological graft as the method to change the synthetic proteases, because synthetic proteases still have a high reinfection rate. And this biological graft is something instead of the own material, but with the very low, in our study, 0% reinfection rate.
In some of these patients, we see as a complication related to infection, so-called graft enteric fistule, so communication between the prosthesis and duodenum or first intestinal loop. Did you have such a patient in this material? This comes from the procedure description, and what was the consequences in regard to the mortality in this group? So can we treat this kind of complication with this prosthesis?
Yes, if I remember correctly, we have 2 patients with this complication, and all of them died during the postoperative period. The clinical presentation was very severe during the admission, and unfortunately, they didn't survive the postoperative.
Thank you. And second question, this is quite new technology in the vascular surgery. Does this patient, because this is xenograft, as you mentioned, and does this material require the special treatment postoperatively? So if you want to keep this patent for the rest of the patient life, and this is not allogenic material, I understand this is the static material, no living cells inside. Do we need any special treatment like immunosuppressive treatment or any special anticoagulation or antiplatelet agents? What's your knowledge about?
Yeah, I can answer according to the characteristic of the product, because I know that there's a xenogenic graft, so it's made from bowel pericardium, so we do not need any drugs to prevent the prevent the rejection of the graft. But we do need pharmacotherapy, because the producer admire to use the antibiotic therapy for 6 weeks. Besides that, we have to use the anticoagulant and anti-aggregant therapy. Anticoagulant for at least 6 weeks and anti-aggregant therapy for 3 months. And of course, the antibiotic, as I said. But we do not need to use the immunomodulators, because the reinjection rate is really low. But in the literature, there are some cases described about the acute rejection of this graft, but it's a very, very rare situation.
Yes, of course, but if you could wait for the microphone.
Thank you very much. Congratulations on your presentation. I think that this is the most important problem in modern vascular surgery, infection of artificial graft. But very important is treatment these patients. But according to me, the more important is prophylactic. Where you see sources of infection in artificial grafts in vascular surgery, and what do you think about prophylactic? What is the most important in prophylactic?
Yes, actually, according to the recent studies, even the bacteremia during the, for example, dental procedures can be a factor for graft infection. So even the slight procedures that involve the vascular damage can unfortunately perform to vascular graft infection. And prophylaxis actually right now, especially in dental procedures, we should use antibiotic prophylactics about 30 minutes before the procedures. to prevent the infections.
So we would like to highlight just the consultation with the dentist, with the laryngologist, because it's the most common sources of the infection in those patients.
Thank you very much for the presentation and discussion. Unfortunately, the time for the discussion has passed out. So now I'd like to invite on the stage the author of the last, of the 9 presentation. It's the comprehensive patient education in endovenous laser ablation.
Okay, good morning, ladies and gentlemen. My name is Jonasz Osiecki. I'm 4th-year medical student, and together with Aleksandra Podraszka, we have developed a study entitled Comprehensive Patient Education in Endovenous Laser Ablation, exploring contraindications, outcomes, and complications. It is my honor to represent the Medical University of Silesia in Katowice. Varicose veins are often underestimated by patients because they associate this disease only with unsatisfactory aesthetic effects, while untreated varicose veins can become a serious health problem. In the European population, this disease affects the chronic venous disease affects from 40 to 60% of women and 15 to 30% of men. As the most commonly symptoms or signs, we have swelling, painful muscle cramps, or dull pain. There are various methods of treating chronic venous disease, ranging from conservative to surgical approaches. And today, I will discuss the one of them. EVLA, endovenous laser ablation, is gradually replacing traditional surgical methods of treatment. This method does not involve removing the varicose vein, but eliminating their cause, which is the incompetence of the main venous truncus. The most common is saphenous vein, and less frequently is perforating vein. The action of the laser here is based on the phenomenon of selective photothermolysis. The laser selectively destroys certain tissues, and the most modern lasers uses a wavelength of 1940 nanometers. This method is popular due to its short operation time, reduced bleeding, and quick recovery. And here on our film, it is possible to turn it on because it should be. Okay, no. So in the attached video, we should see this procedure in practice. We locally anesthetize the insertion site somewhere here. And after that, we introduce the fiber optic into the vein and using laser energy, of course, under ultrasound guidance, we induce the collapse and shrinkage of the vein. And every surgical procedure has its indications and contraindications, and EVLA is no exception. On the slide above, you can see the most important of them listed. And of course, surgeons, after performing this procedure, often have to deal with complications, and the ones that most frequently occur after EVLA treatment are swelling and bruising at the site of laser action. However, much more serious complications, which clinics often do not inform their patients about on the websites, include deep vein thrombosis, skin burns, damage to superficial nerves, and superficial thrombophlebitis. And patient awareness regarding the procedure and especially potential complications is crucial in the decision-making process for undergoing EVLA. This procedure is often advertised as minimally invasive with minimal possible of complications, but as you saw, it is not exactly true. So there are 5 pillars in the decision-making stages for clients of medical services. These include problems or problem recognition, information search, evaluation of alternative solutions, purchase service, and post-purchase behavior. Therefore, if a patient decides to purchase a medical service based on the benefits of the EVLA procedure and fails to find information about the complications due to the difficulty to finding them online, it's highly unlikely that they will change their decision and withdraw from it once they are discussing complications with doctor. And it's also worth noticing that as doctors, we are obligated to inform the patient about the procedure complications, because if we fail to do so comprehensively, we leave room for potential claims from the patient in case of complications and adverse effects. So we decided to verify the quantity and quality to information reaching patients regarding the procedure and its complications. We also wanted to assess the level of education provided to patients by medical staff regarding post-procedural care. Our study was conducted analyzing data gathered from the websites of 50 medical centers in Poland, offering endovenous laser ablation treatment. The information provided by these centers was categorized into 5 sections: general details about the procedure, description of indications, details on contraindications, guidelines for post-procedure care, and potential complications. And also, during the analysis of phlebology centers, we identified 4 most commonly mentioned complications, which are discomfort, swelling, pain, and skin discoloration. And on the slide above, we see a table that describes in percentage values the frequency of occurrence of various EVLA treatments complications. Among the data analyzed, less than a half, because only 46% of medical centers provided information on contraindications to potential patient, while just 42% mentioned possible procedure complications on their websites. Unfortunately, information about the most serious complications, such as deep vein thrombosis, pulmonary embolism, or perforation of the operated vessel, was only indicated in 10% of the surveyed clinics. We also noticed that 76% of clinics educate their patient about post-operative recommendations, but the majority of them only focus on compression therapy. And moving on the conclusion, medical centers specializing in the treatment of varicose veins present EVLA as a minimally invasive, painless procedure which carries a minimal risk of complications for the patient. To attract the patients, private medical clinics only inform patients about the indications for the procedure, but not provide enough information about the complications. Thank you very much for your attention. I invite you to discuss.
Thank you very much for the presentation. Do we have any questions?
Thank you for your work. I think it's very important and it's really worth to mention this problem. In your opinion, do you think we should create maybe a website or generalized guidelines or general informations for the patients, or a place where they can find proper information, which include all the indication, but also the complication? How would you solve this problem, which you presented us?
For me, such a website will be very good, and maybe it could solve the problem, because, for example, for me as a medical student, it was hard to find, or for example, complications. So the website that will have the all specific information that the patient should know before he or she decide to do this procedure, it could be very, very helpful, and I think it could be a very good solution.
Congratulations for your work. I have a question. Could you tell us more about selective thermolysis?
Yeah, of course. The phenomenon of selective thermolysis is the action where we have to say about that every molecule have the another wavelength of absorption the energy. For example, protein have another wavelength to absorb the energy from the hemoglobin. And here in endovenous laser ablation, our chromophore, so this molecule that absorb the energy from the laser, is water, and the most modern are, as I said, 1940 nanometers, and where water in the veins absorb the energy by this wavelength, the temperature is increased and the vein collapse and shrink.
Thank you very much.
Thank you.
Okay, and we have time for eventually one more question. Do we have a question from the jury?
Okay, so congratulations on pointing out, I think, quite a substantial problem regarding medicine altogether and the tendency to report or discuss with the patients the potential complications and adverse events that may arise after certain procedures. I'm curious, during your analysis of the most severe complications, have you come across any actual legal complaint that was maybe discussed among the patients on medical forums or such?
No, because I analyzed the website, with the website of Laboratory Center, but also saw social media and medical forums, and I did not find a discussion about the complaint of the patient.
Thank you very much for the presentation and interesting discussion. And now we proceed to the last presentation, that is video-based multimedia information in reducing preoperative anxiety, a randomized interventional study.
Good morning, esteemed jury and my dear colleagues. My name is Palak, and I'm here to present our randomized interventional study titled Video-Based Multimedia Information in Reducing Preoperative Anxiety. The feeling I am feeling right now, and most of us would have been feeling while walking up to the stage, is anxiety. And the way we respond to this anxiety determines our performance and thus the outcome. Therefore, making the basis of our study, that's surgery in itself is very stressful, physiologically as well as mentally. The studies suggest that 25 to 80% of the people undergo stress, that's called preoperative anxiety before the surgery. And we as physicians tend to neglect the mental assessment over the physical assessment. And for patient care, we need to include both mental and physical assessment. So as healthcare workers, it's our responsibility to come up with studies that include both of them. That's the background of our study. It's a randomized interventional study. Patients posted for major and minor surgeries. Our intervention was video-based assisted information, and the normal comparative arm was the conventional pre-anesthetic counseling. Then we used the questionnaires such as APIS and STI to measure the preoperative anxiety, which I'm going to come to in the coming slides. This is our intervention, the video-based multimedia approach. Videos, the most easy way to comprehend information, making Netflix popular among all of us. So similarly, we gave our patients 5 to 15-minute videos, and the source was yourpractice.net. They were given language assistance before the video, for the video, as there were local languages also. So this was the intervention. This is the study design. It's a pilot study. The sample size was calculated using G power of 45. And after attrition, we were left with 41 participants. It's a single institutional study, and also single blinding was followed. It's a simple human randomization study. And after human randomization, the groups were divided into cases and controls. The cases were shown the 5 to 15 minutes videos of the procedures, and the controls were given a brief introduction before anesthesia. The inclusion criteria was patients posted for surgery, for elective surgeries, and the age group included was 15 to 75 years. We excluded the patients who were psychiatric patients if the videos were unavailable or the surgeries were emergency procedures. And then after the intervention, we gave them the questionnaires, that's APIs and STI, which I'm going to show you in the consecutive slides. And we took the preoperative anxiety scores, pre-intervention and post-intervention. This is the API score. This is the Amsterdam preoperative anxiety inventory, anxiety and information score. It is divided into 6 questions, having questions about anesthesia, surgery, and it's a Likert scale analysis, scoring from 1 to 5. And then there's STI, that's Spielberger straight rate anxiety inventory. It's 20 questions divided on positive and negative impact. APIs tends to have questions more on anesthesia and surgery, and STI is more about the personality traits, how you are feeling, positive or negative. These were the demographics of our study. As you can see, interestingly, both cases and controls had the similar age group of patients. The male and female population was also similar. As you can see, we also divided them on the basis of education. As most of the patients you can see in our studies were not well educated, making videos the best way for them to comprehend the information about their surgeries. Also, we checked if the people were online information seeker or non-seeker, because that is important, because curiosity, people tend to be curious about the procedure they're going to undergo. So that was important as well. This is the APIs analysis we performed, the anesthesia component, the surgery component, and the total component. As you can see, pre-intervention and post-intervention scores did have positive mean difference, establishing that there was reduction in preoperative anxiety after our intervention. Also, when we checked the recommendation scale, these people were very likely to undergo the procedure if required in future. This is the STI questionnaire. In this, we analyze it on positive component, negative component, and the total score. Here also, as you can see, the mean difference is positive, establishing that here also anxiety scores were reducing after the intervention. And also by the recommendation, these people were also very likely to undergo the procedure in future if required. So what do we infer from our results? We infer that both participants demonstrated equal reduction in anxiety post-intervention in both APIs and STI group. In the API subscales, if we could see the Pearson's coefficient, it established a strong relationship between the anxiety scores and the intervention. Therefore, the Cohen's d-effect size was also quite significant, emphasizing the practical importance of reducing the preoperative anxiety. In the STI group, there was also a clear association between the intervention and the anxiety scores. The Pearson's correlation was not that severe as compared to APIs, but it was also modest. Also, the Cohen Z effect. Therefore, it showed the reduction of anxiety scores over time. Clinical significance. So what is the clinical significance of a study? Our study establishes, especially in developing countries like India, where population load is so high that the doctors are not able to give patients the proper time and counseling they need before the procedure. Such kind of studies are actually needed, where the patients can be fully educated about the procedure they're going to undergo. Therefore, a holistic approach for the patient care. On the side, you can see it's the PI of our study who's collecting the data from the patients. Also, future research is required in this area to establish better results. anxiety questionnaires, which we utilize for APIs and STI, as they had different types of questions, though they are good, but we need hybrid questionnaires, such as which can be better in better way, tell us about the anxiety. Because APIs was just talking about the surgeries and anesthesia, and STI were just talking about the personality. So we need hybrid questionnaires that can establish a better understanding of the anxiety scores. And video interventions should be adhered to the personalities of the patients and comprehension. And more extensive trials and bigger RCTs, which we are planning, are required to have a better understanding of the of our results. Limitations, our study did come up with its own limitations because the sample size was low. It was just 41 participants. The variations were minimal because it's a single-centered study. The video intervention was from a generalized source, so it was not personalized according to the people. Conclusion, our study did establish reduction in anxiety scores with positive mean difference. Our study supports the need of video counseling for a better patient care. And also, the patients showed higher willingness to undergo the procedure. Therefore, a happy patient is equal to a happy doctor. Thank you. These are the references.
Thank you very much for this interesting paper. I have 3 questions concerning this. What about the influence of the families and relatives? Because many of these people are coming to the hospital alone and they are left as they are, some of them. So do you have any data if the presence of the families and relatives can have influence on this, what you found? And perhaps you answer first the question. Yeah?
Thank you for the question. And I do believe that, yes, the presence of families and their peers would obviously reduce the preoperative anxiety. But unfortunately, we did not include these factors. We were just including it was solely based on APIs and STI, which we do believe is a limitation because we should consider more factors as well. And hopefully, if we plan a better RCT, because it was just a pilot study, if we plan a bigger RCT, we'll try to include these factors as well.
And in data, how the level of education influence on the results. So this potential, I mean, the possibility of understanding this, what happens around, can potentially be valid in case of such analysis.
Yes, actually, we did notice that the people who were less educated had a better understanding as we showed them the video in the local language. It made them understand the procedure better, and the preoperative anxiety scores did reduce in those patients better compared to the other patients. So, because verbally, when a doctor is explaining, we tend to, as a physician, we tend to use scientific terms and medical terms, which are not easily understandable by the patients. So we believe that when we showed them these videos in the regional languages, it was easier for them to understand and visually understand what's going to happen to them. And it gave a better reduction in preoperative anxiety scores.
Okay, and last question, which I have, because one of the points of the assessment is creative own contribution. So what was this your and students' creative own contribution, this study? This was the study initiated by the students, provided by the students, or this was just a part of the bigger project?
Actually, it's a study by us students, me and Rohit, the first author. We are the co-PIs of the study. We came up with this idea, and I did the IRB writing as well. And we went to the hospital in Bangalore, and there we took the ethical consents and everything. So it's a study done by us students.
Thank you.
Thank you for the question.
Okay, so congratulations, because this issue is of an utmost importance, I think, in our daily clinical practice. And as an anesthetist, I find that I need to be as often a consultant as I need to be a therapist. And I didn't quite catch that in your results. So was there a difference in the number of patients that were more afraid of the anesthesia than of the surgery itself? Or were they generally more concerned with the procedure?
Yes, as the APIS questionnaire did have the anesthesia component, surgery component. So we did do the subgroup analysis, but I didn't put the results here, unfortunately. Yes, there were patients who were more afraid of the anesthesia compared to surgery, because that tends to be more scared to them because they believe they won't have control over it. So yes, actually that was noticed as well, that the patients who were undergoing, they were more afraid of the anesthesia as compared to the surgery itself.
we also tend to notice that during our preoperative consultations that it's very important for the patients to understand what will happen during the induction of the anesthesia. So thank you for that.
Thank you for the question.
And we have time for one more question, if there is any. Saying none, thank you very much for the presentation and for the discussion. And with that, all submitted papers have been presented. I'd like to congratulate all of the presenting authors and participants of the session of surgery too. At this point, I'd like to ask the president of the jury for a few words and to sum up the session.
Okay, ladies and gentlemen, dear students, just a few words in the end of the session. I know that there will be just one winner, one second place, one third place, but I'm sure that all of you won today because first you did your own work. You decided to do this. You went through the problems which are usually on the way, starting from the literature research through analysis. Many of you did this for the first time, and this is something which you are not able to learn during normal training at the university because there is no time. You are overloaded with the program, seminars, exams, whatever. But this, what you did today, you did just for yourself personally, and you will remember this when you finish your study. That one day, this was 2024. You started to work on your further education development and also understanding how some of the things can be done. So for me, all of you are winners. If you want to get the first prize, you can try next time. One day this will for sure come. But all the papers very, very good. It's my opinion. Some of them, of course, needs perhaps a little bit improvement and preparation, but I know that many of you really did this for the first time. So congratulations. Presentation as personally for me, the level was very high. I understand you had the various topics. You are coming from various centers, but believe me, it's not a waste of time. Years ago, someone gave me the hand when I started to do some research, or I wanted to do this, and this was probably one of the most important moment in my life. So I encourage you to continue because you stand right now on the right pathway to develop and to create this what you are able to do. And if I can have a short summary, Wacek, you are the director, Wacek? You are director from the course of surgery. So if you can say some words, because we encourage the young people to join surgery. It's a surgical session. And one of the problems recently is that a surgery is a hard work. And this was always hard work. And this will be hard work also in the future. This is the discipline that right now probably is not as commonly chosen as was years ago. But there is still place for the young, intelligent, clever and creative people in this discipline. That's why we, with Professor Kuczmik together, we encourage you to go this way and to find out your place in surgical field, where there are really various options to choose whatever you want. You don't need to be all orthopedic surgeons removing hips and knees, which takes a long time at the table in X-radiation and the hard work, which is of course wonderful and interesting, but there are various other options. And also in surgery nowadays with this all new facilities and possibilities which we have, also technical improvement, especially for example, in our part is vascular surgery. It's really a change of the time, and this will change also in the future. I don't believe that during your life there will be tablets created for all the diseases. Probably many of them will need the invasive treatment. That's why we, together with Professor Kuczmik, we encourage you to go this way and to stay with surgery, vascular surgery. And for those of you who are really active and interested, I think that we can come back to the talks about your future if there will be someone interested in vascular surgery. I think you can try to visit Professor Kuczmik with your CV, and then would be really great to have some things inside which are also based on on today's presentation. So congratulations once again. And the final comment, Professor Kuczmik, the director of the surgery course at the university.
No, I only a few words. I absolutely agree with Professor Urbanek. And we are very happy when we see you, how you work in together with our departments, and the efforts of your work we see. Congratulations for all. It was fantastic presentation. Probably one will be the best of the others, but all was very fine. And of course, we think that some of you come to our departments, and we will be work together in many years in future. I invite you together with Professor Urbanek. Congratulations again.
Thank you, Professor Urbanek, Professor Kuczmik, for these words. And I also like to truly appreciate comments, observation, and work on the presentation assessment of all members of our esteemed jury. So Dr. Dorota Łyko, Dr. Agnieszka Wiórek, and Dr. Marianna Łoskot. And with that, I'd like to conclude our session and invite you to the decoration and closing ceremony of the SIMC 2024 conference, which will be held in Theatre Rialto on Friday at 6 p.m. On behalf of the Student Scientific Association, I'd like to thank you all for participating in this session. Thank you and congratulations.
Thank you very much.